Hi, we're going to get started. I'm Sandy Springer, and we have two more speakers in this great topic here. And the next speaker is Dr. Jody Rich, who I've known for quite a while. And he is a professor of medicine at the Warren Alpert Medical School of Brown University. He's also a practicing infectious disease specialist and also addiction medicine board certified. I have to plug that, even though it wasn't on your board. And he has been providing care there for over 22 years. And in particular, he's been involved at the Rhode Island Department of Corrections, caring for prisoners with HIV and those with opiate use disorders. And he is going to speak with us today about the correctional health care population and the intersection of opiate addiction and infectious disease. Thank you.
Thank you, Sandy. It's an honor to be here, and I really appreciate being asked to come here. I'm actually, the last 24 years, I've spent a half day a week behind bars, but I've also been released from behind bars every week for the last 24 years. And I'm going to kind of reflect a little bit on a quarter century behind bars. I went in because we had the AIDS crisis, and I went in to take care of people with HIV. And looked around and saw that there was a lot more than just HIV going on behind bars, including addiction, including opioid use disorder. And that, so for most of this time I've been working on mostly HIV care, but the last several years working on opioid use disorder, as that's become much more prominent. There's a lot of similarities between what was going on then. We didn't have we had a lot of people, young people dying, and now we have a lot of people, young and middle-aged people dying. I really appreciate Carlos's words this morning talking about the social justice issues, because they're very similar. And, you know, prisoners are a stigmatized population, as are people with HIV, as are minorities, as are poor people. But none of that compares in international studies to people with addiction. They are perceived as the lowest of the low, the subhuman, and really that pervades our culture. If we take a step back and see what are we doing, you know, where are we putting our resources to deal with addiction, and particularly opioids, but addiction in general in this country, we are pouring, you know, hand over fist resources into the criminal justice system. And unfortunately, punishment does not seem to work with this disease. So we are wasting, we're squandering, we're filling our jails and prisons, and we're getting nowhere. In fact, we're slipping back. And so I think, you know, it's said that you shouldn't let let a crisis go to waste. And so, yes, I would love to get rid of this epidemic of opioid overdoses and opioid use disorder and associated infections, but I think we really should also think about using this as an opportunity to really examine the stigma that we treat people with this disease with, and not just the people that have it, the people that provide care, the programs that provide care, the neighborhoods and the family members and so forth. So I was a former stockholder in Academies. My father helped to found the company and gave me some stock. And so I've been a stockholder since they were formed, but unloaded it last year. So I also want to thank NIH, particularly NIDA and the CFAR for support of a lot of this work I'm going to talk about. So I'm going to talk briefly about the epidemic of incarceration, the current opioid use disorder epidemic, overlap with infectious diseases, and what we can do about it. A lot of this has been covered already. So this is a cover of Time magazine from 1982. Ronald Reagan was president at the time, peeking out of the corner there. And at that time, we were wondering, why are we incarcerating so many people? What are we having this for? So 1982 was right about there, the inflection point on this graph. So we were wondering why we're incarcerating people, and then we took off. Now, of course, all of this area above, now this area here is pretty much where the rest of the world is in terms of incarceration rates. And all of this area above the curve here is really the war on drugs and inadequate treatment of mental health disorders. The area below the curve, that's all just testosterone. Just kidding. Just kidding, sort of. All right. This is a billboard outside Reagan National Airport put up by the NAACP saying that welcome to America, home to 5% of the world's people and 25% of the world's prisoners. And it's appropriate that the NAACP put that up because there's just striking racial disparities Nick alluded to, more prominent in the South, but throughout the whole country. 1 in 9 men are likely to be imprisoned, 1 in 17 white, and 1 in 3 black men, and 1 in 6 Latinos, and women less so, but the disparities are still striking. Now, this really points out that more than half the people have some problem with drug and alcohol and mental illness, and many with dual diagnosis. If you look at opioid use disorder, it's usually around 15%, give or take. Now this was work that Ted Hammett did, looking at the population. Now we have about 2.2 million people behind bars. About a third of that are in jails, and about 2/3 are in prison. Of the people in prison, about half turn over every year. So maybe 700,000 come in and out like a tide. We talk about tides because we're in Ocean State in Rhode Island. The jail population turns over like crazy. So there's about 10 million people coming in and out each year. And if we look back in '97 at the proportion of HIV, people with HIV in the country passing through, almost a quarter of people with HIV cycled through mostly jail. And you can make a similar calculation for, and he did make a similar calculation for hepatitis B, about a third of the hepatitis C and TB. So there's been a dramatic overlap between infectious disease and incarceration, and between incarceration and addiction. Now, we knew when we finally got effective antiviral therapies in the mid-90s, we saw a dramatic drop in deaths, and we all of us who were providing care, we felt it, palpably, and we got together at a national meeting and pinched each other and couldn't believe it after so much death and destruction. And there was a similar drop in deaths, AIDS-related deaths in correctional settings. So we knew that somebody was getting antiviral therapy on the inside. But really, we know very, very little about the health care that's provided behind bars. There's very little accountability, there's very little standardization, and really the only accountability is with through litigation. There's other countries have real evaluations of what's going on, what kind of health care is going on, and other kinds of care and treatment for prisoners. We don't have anything of the sort here. This is some work done in Texas. So there were over 2,000 people that were on antiviral therapies and discharged. They were given 10 days worth of medicine, and then they looked to see when they filled their first prescription for antiviral therapy. And so they had to fill it within 5 days to continue their therapy. And so 5% filled it within 10 days. So that means 95% of people on treatment with HIV released from the Texas Department of Corrections interrupted their therapy at a time when they were just coming out, either re-engaging or newly engaging in sexual relationships and relapsing to drug use. This is like the perfect storm. This is absolutely the wrong time to stop antiviral therapy, because we know antiviral therapy prevents much transmission. And even after a couple of months, only 30% got filled their infection. So we're doing a pretty good job on the inside, or providing care for people with HIV. We're doing a pretty good job on the outside, and in this transition, it's a big drop-off. Now, Sandy just presented some really exciting data. She's been working in this area for a long time, presented some great data last week at Croy showing that treating opioid use disorder and HIV has some synergistic benefits, and is really very exciting stuff. Okay, now I'm going to switch to the opioid epidemic. And, you know, the slope of this curve is just getting steeper and steeper. This is bad. You know, this is where we peaked in gun violence deaths. This is where we peaked with HIV in 95. This is where we peaked with car crashes in 1972. And we are heading in the wrong direction very rapidly. And of course, a lot of this is from fentanyl. And it's everywhere, and we've kind of heard that already. And we heard about Scott County, and we also heard that that's prevalent elsewhere. Now, Nick stole a lot of my thunder, but these are counties where they're almost identical to Scott County. They could pop at any minute, and probably are popping. And a lot in Appalachia and through the south and some in the west. And this is our incarceration rate. Again, through the south and a little bit Midwest, much higher rates of incarceration. And looking at the social determinants of health, it's again all concentrated in the south and over towards the west. Poverty, income inequality, poor education, lack of health insurance, and lack of health care. It's a perfect storm going on. And then, of course, we have the that's almost an overlap with the lack of Medicaid expansion. So we have lack of access to health care in the places where we really need it. Now, I say opiate use disorder is really poorly understood. I think the key thing about opioid use disorder and addiction in general, the key defining characteristic is its use despite adverse consequences. So people don't have control. And that's like I said, similar to what I said, that punishment doesn't work. People often need to, they can get in and out, as we heard this morning from that such a vivid description of using and then getting off and then using again and getting off, on and off the bicycle. Now there's three factors that contribute to the development of opioid use disorder. The first one is the genetics. So it's almost, genetics is probably one of the more powerful one. The second is, I call it, the situational characteristic, and that could be, peer pressure. You're just hanging with the wrong crowd and everybody's using, and so you could use. But it's also often trauma. It's almost universal in the women I see that they've had horrible traumas, and we heard that story today. The woman said she was, sexually abused as a young child. That's almost universal. And if there wasn't a trauma before starting opiates, there's almost certainly trauma afterwards. It's also very common in the men. So if you've got molested as a child and then you were told, no, that never happened, and by the way, if it did happen, it was your fault, and we don't talk about it, and you're carrying this burden and you're going through, into your adulthood, and then all of a sudden you get this substance into your body, and that burden just kind of lifts off your shoulders, and I feel good. That's okay. Doesn't matter. Life is okay. Why wouldn't you want to go back to get that again? So the third component, the genetics, the situation, and then the exposure. So you can have all the trauma in the world and the worst genetics. If you never try an opiate, you're not going to get opioid use disorder. But that's the thing we've changed. We've flooded the market with prescription opiates. Nick's description was fantastic of how many pills, 300 millions of pills. So they start with the pills, then we heard the story already today, they transition to heroin because it's cheaper, and then they transition to injecting because their tolerance goes up. There's two fundamental characteristics of opiate use, not even opiate use disorder, about the opiates themselves. The first is tolerance. So that means the more you use, the more you need to use. You need a higher and higher dose to get the same effect. So this is just a cartoon schematic, but you see this is kind of trending down. You use, you get high, and then it comes down, and then it wears off. So that's what happens in the beginning. The second characteristic, and this, again, both of these can happen in days to weeks, is the withdrawal phenomena. So when you go into withdrawal, and withdrawal is, imagine the worst flu you ever had, imagine the worst stomach bug you ever had, put them together and multiply it by about 1,000, and that's how you feel. You literally feel like you're going to die, and you behave as if you're going to die, and you will go to the most desperate, desperate thing, do the most desperate things to avoid that or to get out of it. And that's really the most diabolical characteristic of this disease. So, initially you start using, and you get this euphoria, you get this pleasurable feeling, you get the pain relief, and then you start going into withdrawal, and then you're just trying to get out of withdrawal. A lot of patients will say to me, "Doc, I don't even get high anymore. I just want to feel normal. I just want to be up there feeling normal." So the more you use, the more you need to use, you get more and more desperate. People typically will resort to stealing, or getting involved in the sex trade, or getting involved in the drug trade, or if you're really good, telling stories. All right. So the treatment, so what can we do about it? And we hear a lot of the political discussion about treatment beds, and what they're talking about is a detox. So you put somebody in, you detox them. Now the problem is, all this time that somebody's been using and using and using, they are doing operant conditioning, just like Pavlov's dog. They're getting a positive reward when they use, and when they don't use, they're getting a very negative reward. And so they've changed the pathways in their brain to really respond like, I need this medication. A lot of people don't understand that. I tell a story about a patient of mine who was locked up. He'd been locked up for a year, hadn't used behind bars, and he's sitting around playing cards with his buddies. And one guy said, "Hey, remember that first time you got high, how great it felt?" Another guy said, "Oh, I remember I once felt so good, I got so high." And they're telling these old war stories. And within a few minutes, you look around the table, and they're all starting to sniffle. Their nose, they're getting itchy. They're getting goosebumps. Their pupils are dilating. They have been locked up. Their lives have been turned upside down because of this disease they have. They have plenty of reasons not to ever use again. And they are experiencing physiological withdrawal. I guarantee if I put some drug right on the table there, they all would have used it despite consequences. Hadn't used in a year. So that's just tickling those ideas, just a little visualization of a little thinking about it. And so, when you think about all the challenges of transitioning from being incarcerated to back in the community, it's a wonder that anybody is able to make that transition without relapsing. All right. So there's 3 different medications approved. So the medications in Baltimore, they ramped up medications for addiction treatment and drove overdose deaths down 80%. Similar story in France. So medications are extremely effective. There's 3 currently available. They work by different mechanisms, but they all do the same thing in that they keep you in this normal feeling zone. They block you from getting high, and they keep you out of going into withdrawal. So they keep you normal. So the most important thing about these medicines is not so much which medicine works. They all work. It's which one you're going to take, because if you take it, it's going to work. And they have different characteristics. Surgeon General came out and said the same thing. There's a problem in that many people think that you're not really so-called clean if you are on medicines. You're not really in recovery. You're still one of those people that we should stigmatize. And that attitude is really killing people. I have patients that come in to the prison, they sit on this chair, I talk to them, and I said, what happened? They said, well, I was doing great. I was on my medicines, I was taking them, I got my wife back, I got my kids back, I got back to work. And then my wife said, what are you still taking that stuff for? You're done with that, leave it behind. So I stopped, and something happened, I relapsed, and here I am, and serving another year. And, it's just, these medicines work, and they need to be strongly encouraged. Now, they're not for everybody, they're not perfect, but they're the best thing we have. We have the best evidence for them. All right. So I was fortunate enough to be asked to be an expert advisor to our governor's task force on overdose prevention. And we basically came up with a 4-point plan, but one of them was treatment. And we estimated there in our little Rhode Island population of 1 million, there were about 20,000 people with opioid use disorder. And our goal was to get those people and get them onto medications for addiction treatment. And every place that they touch. So emergency room, the hospital, the clinics, mental health clinics, addiction treatment clinics, on the medical side, but also on the correctional side. Not just the prison and jail. And in Rhode Island, it's a unified system. But in the courts, the police, probation and parole, every point we should be moving over. And of course, what we've been doing previous to that was taking people on medication and then taking them off and then letting them out. Of course, when you take them off their medicine, when you take them off their illicit opiates, their tolerance goes down, and you let them out, and they're set up for fatal overdose. So the governor decided that that's the right thing to do. She put $2 million in her budget, which is a lot in the state of Rhode Island, state monies, to set up an MAT, Medications for Addiction Treatment program, at the Rhode Island Department of Corrections. Dr. Jennifer Clark, the medical director, said, my charge is to care for this population, and this is the #1 thing that's killing these patients. And so I'm going to make the best possible program I can. I'm going to screen everybody coming through the door for opioid use disorder, and if they screen in, I'm going to evaluate them and offer them the best treatment. All 3 of those treatments, whichever best for that particular individual. And I'm going to make sure that we do everything we can to link them up to treatment on the outside. So the task force started the summer of 2015. The funding came through the summer of 2016, and the program started then and ramped up. So 3 weeks ago, we published a study looking at the first 6 months of 2016, just before we started that program, and the first 6 months of 2017, between 6 and 12 months into the start of that program. And what we looked at was overdose death rates in the state, statewide overdose deaths. And so what we saw was a 12% drop statewide at a time when the curve everywhere else in the country is continuing to go up. And so 12% overall drop in those two, comparing those two. But when we looked at people who had been released from incarceration within the previous 12 months, we saw a 65%, or an absolute relative risk reduction of 61%. So that's a 61% drop in overdose mortality by connecting people onto medications for addiction treatment in incarceration. And this was within 1 year of starting the program. So we've seen nothing like that, dropping overdose deaths in the setting of this epidemic. So this is quite clear that we need to do that. Now this slide I stole from Nick Zeller. And the point of this slide is to show that there's really no point in starting a treatment program behind bars if you don't have someplace to connect people to. So if you don't have a methadone program in your county, and your county jail wants to start a methadone program on the inside, you better start one on the outside. So you need to ramp up. Similar for buprenorphine. So I, unfortunately, am out of time. But I would just say that the natural history of this disease leads people to involvement in the criminal justice system, leads people to risk for infectious diseases, and that we can play an important role in reducing this epidemic with partnering with the criminal justice system. And I'll take questions. Thank you. Yep. Okay.
Any clarifying questions for Dr. Rich?
Or obfuscating questions?
So, Jody, let me just ask one question. So, great work with the reduction in opiate overdoses. That's awesome. How do you see that expansion of medication-assisted treatment for criminal justice populations coming out of prison and jail also impacting HIV and hepatitis C in terms of also not just those who are living with HIV and maybe improving the HIV continuum of care, but also potentially for prevention efforts as well?
So these are preliminary results, and we, as soon as we saw this, we said we need to get this out because, we're in the midst of a horrible epidemic, and this is something, although not easy to do, a lot easier than many other things that are out there that are not working. So we had a sense of urgency to get it out. And again, so we just looked at overdose deaths. That's really the tip of the iceberg in terms of the impact. Anybody who knows a family who's had this disease knows that this disease burns a swath through the family. And so the other consequences, including HIV care, including hepatitis C care, including any kind, it is a horrible, devastating disease, and all the much more horrible because of the terrible stigma around it. So, we showed a drop in mortality, but I'm sure there are many other impacts, including improvement in care. Yeah.
Hi, quick question. Could you speak a little, Jody, about the process by which you convinced Corrections in Rhode Island to be okay with agonist therapy? And Corrections,
Sure.
in my experience, is very focused on antagonist therapy. It lines up
Right.
with sort of their agenda, and it sounds good, and it's antagonist. But it's hard to get them to accept agonist therapy.
Well, so we've had a number of interviews with the press, and one of the points we've emphasized is that we offer all three medications. And when it's wonderful. I sit down with a patient and I say, okay, well, what have you tried in the past for this disease? And they say, well, some people say, well, I tried methadone and I just felt sleepy and groggy and I couldn't get up every morning to the program. I didn't feel right. And I had a guy last week who said, a funny thing happened to me. I got into methadone and I felt like I wasn't high and I didn't need to get high. And it was this bizarre feeling. And I said, that's how most people are. That's called normal. Other patients said, I tried Suboxone 3 different times and I just don't feel right on it, and I end up selling my script and buying drugs. But when I got into methadone, I felt like I could live like this. And so I think part of that is probably a biological difference, and to have the ability to offer that to people. Other people say, well, I've tried, we've had very few who've opted for the depot naltrexone. So the first 1,000 patients, approximately half ended up on methadone, about half ended up on buprenorphine, and about maybe a dozen on depot naltrexone. So, the 99% of correctional facilities across the country offer nothing. And the ones that do, most of them offer, we have a Vivitrol depot naltrexone program, but they don't have any follow-up. And frankly, I don't care which one you take. If you take it, it's going to work. The problem with Vivitrol, and there's more evidence coming to show that Vivitrol is effective, but if that's the only thing you're going to offer, you're not going to see a 60% reduction. And I think it should be tailored. And I've got several patients that said, I want the Vivitrol, we've put them on it, and they seem to be doing well. So, but in terms of convincing correctional authorities, this is a public health intervention in the midst of a nationwide epidemic. And these correctional facilities are public institutions. So, it's fine to say, we shouldn't be thinking that the sheriffs or the correctional administrators are going to come up with this. They're not going to come up with this. But it would be ludicrous for them to say, oh, we're only going to treat diabetes with metformin. We don't believe in insulin. Like, they would never say that. But because these are addicts and there's, abuse potential of methadone, diversion is a problem. And it's a problem. But, that's what they are good at. So they can do their stuff, security stuff around diversion. But this is a public health epidemic. So we can't just say, oh, well, you know what? It's okay, let those 60% of people drop dead after they walk out of our facility because we don't believe in these agonist therapies. No, we can't accept that. That's absolutely unacceptable. That's morally wrong, and it's, we have to just say, you stick to your lane. Your lane is not telling us which medications you can give or not give. That's medical. Thanks.